So welcome everyone to this session. My name's Jane Knight. Here I am. I have my camera on. I'll give you a wave. And I'm a clinical associate with the Medra MSSO. I'm also joined today by my colleague, Dr. Carol-Ann Wilson.
Hello, everyone.
And together we'll take you through some of these examples that we've got to code together. The first slide is our standard that explains Medra was released in the mid-1990s following an ICH initiative. At the time, the Medra MSSO, Maintenance and Support Services Organization, was put in place to maintain and distribute Medra. The activities of the MSSO are overseen by a management committee with representatives from across the ICH regions, both the industry and the regulatory authorities. This is a copyright or disclaimer which explains that Medra is owned by ICH, as is the material that you're going to see today. And although you're welcome to use the material and the examples, we don't make the slides available to you, but there will be a recording so you can re-watch it if you wish. And if you do quote anything from the session, you must acknowledge ICH as owners of Medra and of the material. I mentioned audience participation, making the session as active as possible. So we'd like to use the questions panel for you to ask questions and make comments. Sometimes we don't all agree, and in the interest of time, we have to agree to disagree and move on. We cannot take requests to code specific verbatims today via the questions, but what we can do is at the end, there will be an instant poll survey where you can propose any examples or topics that you'd like us to cover in future sessions. A number of the sessions that we've covered today in all our sessions do come from our audience at previous events. But just I would note there, please make sure that if you're working in a very niche therapeutic area, that the examples you give us are relevant and of interest to the wider audience. So this is how we're going to participate in the polls. You may well have joined us before. The easiest way to vote in the polls is to join with the QR code on the right-hand side of the screen. You can scan this with your mobile phone and it will link you directly to my presentation. Alternatively, you can open an internet browser on your computer or your cell phone and just type in polev.com at the top in the URL field, polev.com, nothing else, and then enter your name, Jane Knight 855, as the username. Then click join. So here's a first poll. We have a new format for this one today. Where are you joining us from today? Where are you joining us from? We realise that quite a number of our attendees come from places which look very small on the map and we might miss you. So if we do this, we're able to see India, Armenia, Denmark, Serbia, Indiana, USA. Wow, good morning, early morning for you. Berlin, Turkey, South Africa, Romania, Poland. So good morning, good afternoon, good evening. Any others that appear to you? Carol-Ann, is someone in Berlin like you?
Yes, guten Morgen.
Welcome, wherever you are in the world. Wow. So welcome. Here's the web-based browser. This is the demo password that you can use. This is the training demo. It will be valid until the end of the week. You can access the web-based browser via our homepage, mssomedra.org, and there's the web-based browser link on the top right-hand side. Carol-Ann's going to put the details in the chat.
Yeah, I did already.
Thank you, Carol-Ann. Here are some of the challenges in coding, and this is what we'll see today with our examples. There may not always be an exact match. Sometimes there's more than one possible approach or more than one term you can use. The PTC document even offers us choices sometimes in some places, and consistency is the main thing that we do uphold, or however we choose to code. Sometimes it's a case that we understand a term differently, and we have to represent the reported events. We have to do the best we can with the best approximation. Overall, we always code as reported without making any assumptions. And here is our cartoon for today. This is what the way I see relates to coding. Sometimes there isn't a perfect matching LLT and you need to use medical judgment. Here you see this unfortunate individual has fallen off the boat, and we've only have categorized life belts for jumped or pushed. Sorry, we don't have one for tripped. And sometimes that's how it feels with coding. Which one am I going to use? Which LLT am I going to use? I don't have a perfect one. And you have to, as we see here, you have to make a best approximation. You have to make a judgment. It's a balance. Coding is a balance between applying rules and using medical judgment to manage the risks to patients. Medical references are helpful to us in understanding the reports and making coding decisions. And sometimes the concept itself isn't in MedRA, and you need to request for a new term to be added to represent the concept. So having said all of that, let's code together. And I'm going to turn my camera off here, because I find it can be distracting for us all. So over to you, Caroline.
I'll make myself presenter. And here we are. Do you see my slide?
Absolutely.
Okay. So here is our first exercise for today. And this is one that we could not cover in the last webinar due to time constraints. The indication reported, so we are talking about indication coding, is Coumarin anticoagulant overdose. So do we understand what is meant here? Is the product used as an antidote to reverse the effect of the anticoagulant overdose? What would be the most appropriate LLT here? And should the overdose also be captured? So which LLT would you select? So please check in your browser and note down the proposed LLT here. I think here's drug overdose would need to be captured. Yeah, but what about the indication? What is it? Drug overdose is the event leading to the therapy, but is there something else that we could capture? Because we were told the indication is a Coumarin anticoagulant overdose. So most of us are looking for the overdose. Is there something else in MedRA that we could use? This seems to be the preferred approach here, drug overdose. This would definitely need to be captured. Yes, it's an overdose of the anticoagulant therapy. Anticoagulation drug level increase, drug overdose. So somebody is proposing splitting here. Bleeding would be an event in the patient. It's, a risk for bleeding. Anticoagulant reversal therapy. So let's look into the browser. You have proposed procoagulant therapy. So we have a lot of choices again, and this really demonstrates that MedRA is very granular. So as Jane mentioned already, there's always more than one option, often at least more than one option to choose from. So we have to take a decision here. So let me close this. And first, look at a reference here. Coumarin derivatives like warfarin and fenprocoumon are potent oral anticoagulants, and their mechanism of action lies in the competitive antagonism of vitamin K. You all know that. They inhibit coagulation, so they prevent the patient from thrombosis by preventing the production of prothrombin. So over anticoagulation may occur during treatment and then represents a high risk for patients. And you can see some recent guidelines for the management of excessive anticoagulation in patients taking warfarin on this slide, issued by the American Society of Hematology. If patients suffer serious bleeding because of excessive anticoagulation, the cessation of the anticoagulant therapy, the intravenous administration of vitamin K and transfusion of coagulation factors is indicated. So now let's look into the browser. Let me switch screens here. Where am I? Oops, I did not find my browser here. Let me open it. Here it is. Session timed out. I have to log in again. Not in Chinese, but in English. Here we are. So now let me search for the string Kuma and see whether we find something that relates to Coumarin. Nothing, because MEDRA is not a drug dictionary, so usually you only find class names for drugs. It holds true for warfarin, I guess. So if we look for warfarin, we won't find any hit here. Fetal warfarin syndrome. So this is something completely different. It's really a medical concept, and it relates to a syndrome of anomalies in the baby when the mother is taking warfarin. So this has nothing to do with our case here. So now let me look for anticoagulants, so more general terms, and search. I have several anticoagulant effect decrease, reversal therapy. This was one of our options. You also suggested it under PT pro-coagulant therapy. Anticoagulation drug level above therapeutic. This was also selected. Circulating anticoagulant, increased anticoagulant effect. That's not what has been reported here. Poisoning by anticoagulants. Again, this was not reported. It's not that it was reported explicitly. It was an overdose. So anticoagulant therapy and anticoagulant reversal therapy. These were both also mentioned by you or proposed by you. Yes, it was an anticoagulant therapy, and during the anticoagulant therapy, an overdose occurred. So, in order to minimize the risk for the patient, then a reversal therapy was, anticoagulation reversal therapy was initiated. So this would be the best approximation to our reported event here. So let me switch back. Here we are. So make sure to understand what the product is being used for, and do not assume bleeding complication, but search for LRTs representing the specifics of the antidotal, the counteractive therapy. Consider general terms as quasi-synonyms for the Coumarin derivatives. And our final suggestion is to code this verbatim to LRT anticoagulant reversal therapy, because this is actually the intent of this therapy. And of course, also the drug overdose would have to be coded, and a query would be needed to check whether the reported overdose was already captured elsewhere. So are there any questions related to this example here, to this
No questions so far, Caroline, no.
Okay, so then let me continue with the next one. And this is quite easy to handle. So lightheadedness due to standing. It's not representing an indication for use in this instance, but a condition in the patient. Do we understand what the underlying condition is? I think it's clear. And is it important to capture the information to standing condition? So please take a decision again and look for the most specific LLT in your browser. Lightheadedness due to standing. Lightheadedness, yes, it's a direct hit in dizziness upon standing. Dizziness, lightheadedness. It's always useful to check the hierarchy in MedDRA in order to see what is considered a separate medical concept and what is subsumed under terms like dizziness, for instance. And always look at the neighbors in order to look for more specific terms for the reported condition. Dizziness upon standing, yeah. Positional dizziness, orthostatic dizziness. We always try to keep as close to the verbatim as possible when coding. So well done. Orthostatic dizziness, dizziness upon standing, lightheadedness again. On standing up. So let me close this again. Thank you for joining. And switch to the browser again. So if I enter lightheadedness, and many of you did so, always use word stems. Here we are, lightheadedness. And it's grouped under dizziness. If I do a right mouse click and say go to browser, I can look into this PT and check the LLTs underneath. Here we are. Here's the PT dizziness, and we see giddiness, lightheadedness, lightheaded, wooziness, woozy are grouped under this PT. But there's no LLT that would capture the information upon standing, due to standing. So here it's useful to look at the neighbors in order to check whether something is more specific, like this PT dizziness. And here we have the dizziness exertional and also the dizziness postural. And if we open it, we see dizziness on standing up, dizziness upon standing, dizzy on standing, and other terms like positional dizziness. As I said, we always try to be as close to the verbatim as possible. What was reported was lightheadedness due to standing, so we would replace the lightheadedness with a synonym, dizziness, and due to standing, we would say upon standing. Or on dizziness upon standing would be the closest match to our reported verbatim. Dizzy on standing, it's an adverb, it's not a noun, so lightheadedness is a noun, so that's why dizziness upon standing would be the closest match to the wording of our verbatim. Lightheadedness would be too vague. Yeah, we would not capture the fact that this was really a dizziness that occurred when the patient was standing. And we see in MedDRA that this is really considered a separate medical concept. So this makes a difference on PT level, and therefore it's really important to capture this information. So here we are. Always try to capture all relevant information of the verbatim and use synonyms for your searches if you do not find a hit in MedDRA at your first attempt. So replace lightheadedness by dizziness and then look for the most suitable term. And here we would code to dizziness upon standing under PT dizziness postural. Are there questions, Jane?
No,
Yeah.
No questions on this one, Caroline. No questions on this one.
Then I give it back to you, Jane.
Thank you. Okay. So do you see that, Caroline?
Yes.
Now, next example is transient vision blurring. So what's being reported here? Is the transient nature of the vision problem important to capture? Is there a medical synonym for blurred vision that we may not be aware of? And overall, what is the most appropriate LLT? Those are the sort of questions we consider with any term, aren't they? So here's a few examples of LLTs for you. Caroline's going to put it in the chat. Apologies, I forgot to put the last term in the chat. So Caroline will put this one in the chat for you. Transient vision blurring. Is it visual impairment transient? Transient visual loss. So we're capturing the transient there, but what about that, the reported condition? Is it intermittent blurry vision, where we capture the blurry and we have intermittent instead of transient? Is it nephrolopia transient? Blurring of vision, visual acuity reduced transiently. So again, transient with the visual problem, or temporary vision loss. So any thoughts on that one? See how your votes are so far. Blurring of vision seems to be the most popular, capturing the exact wording in the verbatim term. Some of you are going for the other transient terms. So before you could all change your mind based on what you see the popular choice is, let's lock the poll. There we see the final result. The most popular is blurring of vision. So let's go to the browser ourselves to see. So I'm going to go to the Medra website. There's the browser and log in. So let's have a look at blur first of all, because that's what we've got. Let's see what we can get with blur or blurred, blurring. Let's try blur, see what we come up with here. So here we've got blurred vision, blurring of eyes, blurring of vision, intermittent blurry vision. That's one of the ones we saw on the, and that goes to the PT vision blurred. All of these go blurring of eyes, there's still vision blurred. So let's take that PT, do a right-hand click and go to the browser. It's multi-axial, so I want to view it in its primary location. And there it is, vision blurred. So let's have a look at what's underneath this. Is there anything that captures the transient nature? So we have intermittent of blurry vision, and we have this nephrolopia again. There it is. Now I put that one in the multiple choice because it is one of the LLTs. And I know when I'm coding, if I do this, and I know that the LLTs are generally synonyms or quasi-synonyms, then I would be thinking, well, what does that mean? And then my next step would be to search and try and find a definition for that condition to see. Because if this nephrolopia means blurry vision, then I've got a good match there with nephrolopia or nephrolopsia transient. Intermittent I wouldn't choose because transient means it's come and it's gone away. Intermittent means it's a series of episodes where intermittent, it comes, goes away, comes back, goes away. We don't know that. The patient may have just had the blurry vision on one occasion. So let's go back to our slides, and I would be looking now to find a definition for that nephrolopia before I make a decision. So looking in Dorland's, which tends to be my first go-to reference, nephro is a combination form denoting relationship to clouds or cloudiness. So this is obviously where the blurriness or cloudiness in vision has come from. We looked further to try and find something else. This was the only one we could find with the nephrolopia together online. And it says that it's dim or cloudy vision from lessened transparency of the ocular media. So it is a cloudiness or blurriness. So based on that, I would be that is what I would choose based on the referencing that we've been able to do and the fact that it's an LLT under the PT of blurred vision or vision blurred. So the learning points here is that we try to capture all the reported elements if possible, and we always code the specific condition. So by this one, I mean, I wouldn't be looking for visual impairment or visual acuity. Most important is to capture the actual condition itself. And if you can capture the transient nature, then that's an additional bonus. Consider synonyms. I wouldn't use one of those synonyms without being able to reference it to be clear that I understood it. And I wouldn't make any assumption of a diagnosis. So the final suggestion there is I would select nephrolopia transient with a PT of vision blurred. Any questions or comments on that one, Carol-Ann, before we move on?
No, there's nothing.
No, there's
for this one.
Thank you very much. I see there's a comment on your previous one there.
Yes.
Yeah. Do you want to address that one?
I can. So dizziness and lightheadedness, different symptoms or the same is one question. As you can see, it's considered dizziness and lightheadedness are considered quasi-synonyms in MEDRA. So if you can see then under lightheadedness is a LLT under PT dizziness. So you can assume that this is it's just a synonym for it's in a different wording. The other one, dizziness is when you feel unbalanced and if the room is spinning. Lightheadedness is when you feel like you might faint. Your body could feel heavy, you might feel nauseous and unsteady, and you may sweat, according to Google. Yes, but you know, both are, we try to capture as much information as possible. And you saw that dizziness on standing is really important information because it leads to a different PT. So it's really a different medical concept. It's a dizziness, a postural dizziness. And I would try to keep to the wording of the verbatim as much as possible. That's why I would go with dizziness upon standing. I hope I could clarify your questions. Could you please show once again how you go from the LLT and search to the PT and other related PT alternatives is one question. Could you show it again, Jane? With the right mouse click and go to browser?
Yes, so here we are in the browser. So I did a search initially here in the center, you just using the browser. There we go. I did a search for the short blur, not the whole word, just blur. This gave me the results down here. And then I will go back to my mouse. There we go. And if I found one that I'm interested in, I could see by clicking, bottom up clicking, all of these LLTs or all the ones I opened were under the same PT of vision blurred. So I could put my mouse on the PT name, do a right-hand click, and I can select go to browser. Go to browser, and that will go to browser. That will then take me, it's multi-axial. The PT vision blurred is in 2 SOCs. Eye disorders is the primary, the default primary location, site of manifestation. That's why it's got the icon at the SOC level. Double click on that and it will take me across to the left-hand panel of the browser to show me that preferred term in relation to the rest of the hierarchy. I can see the brothers and sisters of the term and to see whether there might be anything better, either as another PT alongside it or as one of the LLTs that sits beneath it. Okay, is that all right for everyone there? Any questions, come back to us. Yeah.
There's one other question. One attendee doesn't understand why nephrolopia is acceptable, because this is assuming that the blurring is coming from the ocular media that became less transparent based on the definition that you have shown.
Yes. Now, Carol-Ann and I, we did, didn't we, Carol-Ann? We had this same consideration. At first we thought we'd go for vision blurred, and then the more we looked at it and we decided that we would select this nephrolopia, that it is an LLT under vision blurred, and the cloudiness, the blurriness, we decided it was close, and we decided it wasn't necessarily due to a defect in the specific part. What do you have to add to that, Carol-Ann? Anything?
Yeah, it's really it's a vision problem. So it's clear that it comes from the eye, that something is wrong with the eye, but doesn't assume any ocular structure that is responsible for this blurry vision. So that's why it's still a vague term.
Yes, I think it would be somewhere else. But if you're not comfortable with that, you could select one of the other LLTs. We selected it because we could, we felt it was a synonym of blurred and it had the transient with it. But if you're not comfortable, you could select one of the other LLTs. So the next example is hypochromic microcytic iron deficiency anemia. Now, what type of anemia is this? It seems to have given us a lot of information. Hypochromic microcytic anion deficiency. Can we capture all of these? Do we need to capture all of these? Are they consistent with one another, or does it need to be queried? Should we split code? Are these elements or information about the condition that we need to capture all of them? And what would be the most appropriate LLT? Those are the questions that would be going through my mind when I first look at this term. So what LLT would you select? Again, I've given you a selection here in a multiple choice format. Is it iron deficiency anemia, hypochromic anemia of chronic disease, hypochromic microcytic anemia? Well, that one seems to have picked up a bit more. Microcytic anemia, or would you seek clarification with a query? What would you do here? I'm just going to show the QR code while you're voting, because I think some of our group today have struggled to get the poll. So if you have your smartphone and you want to scan it, there it is. Otherwise, you just type in polev.com. The details are on the top here. Just type in polev.com in your URL. And then when you link to the presentation, you put my name as the username, not your own. It's completely anonymous. So how are we doing? 55 people I see have voted. So where are the votes? Hypochromic microcytic is the most popular choice here by a long way. That seems to capture more of it, doesn't it? So that's the final decision. 67% of you want to code to hypochromic microcytic. So I looked up iron deficiency anemia in Dorland's again, where we tend to go, and it is a type of hypochromic microcytic anemia. So immediately seeing that, and it tells us more about the low or absent iron stores and serum iron concentration, so telling us about the link. So seeing iron deficiency anemia is a type of hypochromic microcytic anemia, that makes me think that iron deficiency is actually more specific. So let's have a look in the browser. Let's go to hypochromic. Let's look at the placement of these terms. Hypochromic and microcytic. I gave it to you in the multiple choice. So let's go straight to that one. Hypochromic microcytic anemia. There it is. It's under PT of hypochromic anemia. Go to the browser, do that right click move again, and there it is, hypochromic anemia. And we see them, normocytic, hypochromic, all types of hypochromic, some are microcytic, some are not. Or we've got, so this is under anemias NEC. Then we've got anemia from deficiencies, and that's where we see our iron deficiency anemia. And there's a whole selection of them there, some of them due to blood loss or other ways of saying iron deficiency anemia. So we've got this choice between these two, haven't we? Are we going to go for the iron deficiency, or are we going to go hypochromic microcytic or hypochromic here as the PT? Or would we split? What would we, based on the Dorlands, I'm going to go back now to the that was what I wanted to show you in the browser. Based on the Dorland's reference that we just showed you, I would code that to the iron deficiency because it says that it is a type of hypochromic microcytic anemia. And in that way, I see iron deficiency as being more specific, So my learning points is that I would look to understand with medical references the type of anemia that has been reported, and is there a relationship between the components that have been reported here. Prioritize the reported information for coding and check all the options. So look at all the options of the parts you've got in your reported term. So my final suggestion would be iron deficiency anemia. Now, this is different from what the majority of you in the group said. So if you have comments on that one, please put your comments in, and between us, we will answer or discuss with you whether you're, what your thoughts are. Any questions so far on that one, Caroline?
No, just a comment from Martin confirming what you have just said, that it is important to capture the pathological mechanism if it is reported, and that it is usually more important than the details of the clinical picture itself.
Because that's what iron deficiency anemia looks like, as you say in the clinical, that if you looked at it under a microscope, isn't it? So it's a more specific. Thank you, Martin, for that confirmation. Thank you. Any other?
There's one question that relates to the blurry vision again. Somebody asked if taking the CODA exam, so certified CODA exam, and select blurring of vision and not the proposed LLT that we have provided, will this be considered an error?
No, I think you would probably, by going blurry vision. I don't think they would have examples where there would be that sort of thing. The exam is much more matching the words. They wouldn't be expecting you to look up things like we did, the synonyms. I think you'd find that the exam would be blurry vision, and you'd find blurry vision.
Somebody says, would it be helpful to confirm the choice, raise a question, to raise a query here?
You could, whether it's worthwhile at the LLT level, whether it's worthwhile to actually ask that. If you're uncomfortable with it, my suggestion would be to select the blurry vision, because they're all the vision blurred at the PT, because they're all LLTs under the PT. I can understand if you're uncomfortable about that, referencing it and selecting it. We ourselves had a bit of consideration of would we choose that one, and we decided we would. But they're both LLTs. If you feel more comfortable matching the words and going with vision blurred, that's fine. I personally wouldn't raise a query because it's such a small difference at the LLT level.
Yeah, and there's another question that relates to the iron deficiency anemia. Could we code both iron deficient anemia and hypochromic microcytic anemia?
You could, but it's kind of tautology, isn't it? You're just duplicating you could then risk double counting, creating two events out of it, because as we said, it is one condition. It's just other ways of describing it. But you could, what do you think, Caroline?
Yeah, I think it's not necessary in this instance, because you would really duplicate. You would have two anemias at the end in your data set, and this is not what you want. So somehow you have to prioritize the information that is provided here.
Thank you. Yes, you're not gaining anything, because that is the picture under the microscope, but that is what iron deficiency anemia is.
Yeah, and the previous attendee with the question just clarifies. So the query was intended for the anemia example. So whether it would be helpful to raise a query here.
I see. Sorry, I misunderstood. I thought it was back on the eyes. Yes, you could, but then iron deficiency anemia is hypochromic microcytic, so you're not really gaining anything. So by querying, but yes, you could, but I feel we're not gaining anything. If we hadn't been able to reference them, that they were different types of anemia, then certainly I would query. But if I'm happy that they're consistent, that is what iron deficiency anemia looks like under a microscope, then I would be happy that they are all the information in that verbatim is consistent. So then my next example, if we've got no more questions on that, is white discharge around nephrostomy site. Now, what's being reported here? White discharge. Is the site important to capture, the fact it's coming from the nephrostomy site? Do we need to query this? And is there an LLT to capture the discharge at that particular site? So these are the questions that I'd be asking myself here before I go to the browser. So I've referenced this for you before I ask you your thoughts this time. So Dorland's said of a nephrostomy, it's insertion of a catheter from the surface of the skin through the renal parenchyma into the renal pelvis under the sonographic or fluoroscopic guidance. So it's something that's done as for urinary diversion or insertion of a catheter, or to gain access to the upper urinary tract as for dilation of a stricture or removal of a calculus. So what happens is when there's some sort of blockage in the upper urinary tract, they put the catheter directly into the kidney itself and drain the urine outside through the surface of the body, through the skin, via a catheter. So it's not bringing the actual urinary apparatus itself to the skin, but inserting a catheter. Usually another reference we found is that it can be temporary. So a nephrostomy is an opening between the kidney and the skin. A nephrostomy tube is a thin plastic tube passed from the back through the skin and then through the kidney to the point where the urine collects. That's the renal pelvis. Its job is to temporarily drain the urine that's blocked, allows the kidney to function properly and protects it from further damage or to clear infections. So this is where we took it from on the internet. There's a picture there for you. So that's what it is. Now, having seen that, what LLT would you select? You can select as many of these as you want. Is it a nephrostomy complication, a stoma complication, stoma site discharge, catheter site discharge, implant site discharge, medical device site discharge? Skin, if it's at the skin, is it skin discharge, or the fact it was white, is it purulent discharge? What would you select here? This example, when you first see it, it looks quite straightforward, doesn't it? I can understand clearly what's happening. The patient's got the nephrostomy in place and there's discharge. So, but when you look at these options, it really does show it's not necessarily as straightforward as you first think when you look at the term itself. Anyone else going to vote? 60 of you, or 60 votes in total. Any more? Any more votes? Few more. Now I think some are looking at the numbers going up. Some of you might be selecting all of them and then you can't be wrong. But here we go. Let's see where your votes have been placed. Nephrostomy complications, a popular one. Catheter site discharge is more popular. Stoma site discharge is the other one. These are the three top choices. So let's have a look in the browser and see what we can find when we look at those terms. Let's start with nephrostomy. So nephrostomy, what do we have there? That's where we see nephrostomy complication, nephrostomy tube placement and removal, or an obstruction to the nephrostomy. Well, none of those are relevant. The closest there as well, there is nephrostomy itself as a place there. But let's look at nephrostomy complication. Well, it has a PT of urinary tract stoma complication. So Medra puts it with other stoma terms. Let's go to the browser there. Again, it's multi-axial, so I select the primary SOC. I could have done this top down. I could have started at the injury, poisoning and procedural complications, chosen the HLGT of procedural related injuries and complications. Excuse me, and then there's an HLT of stoma complications, and it's here along with all these stoma site terms. This is where Medra's placed the nephrostomy. So although it is a catheter, it's been placed here with all these other stomas. Nephrostomy complication is an LLT, as we saw, under the PT of urinary tract stoma complication. So that makes me think, if this is regarded as a stoma, then stoma site discharge, the term up here, Stomach discharge. It has some sibling LLTs of leakage, secretion and exudate, but we've been given the wording discharge. So that seems like a good match because the nephrostomy down here is clearly treated as a stoma. Let's have a look at the other option that a lot of you chose, that was catheter site. So I can again do top down. Catheter site would be within the general disorders and administration site conditions. And I'm going to do, I could do it bottom up or top down. Administration site reactions, application and no, where's my catheter site? Where's my catheter term there?
Below.
There we are, implant and catheter. Sorry, I'm leaning forward. There we are. The catheter, implant and catheter site reactions, and there they all are. Thank you, Caroline. Catheter site discharge is a PT there. Catheter site discharge, and the LLT and PT are the same, and it's under implant and catheter site reactions. Well, it does seem that our nephrostomy is a catheter. So it definitely is. It's not a natural part of the body that's brought to the surface, but we always say to people, check the hierarchy. And when I look at this hierarchy, I could, before seeing this, I could, in my mind, I could equally be happy with catheter site discharge or stoma site discharge. I think either of those could have been selected for the reported event. It is a stoma, but it also is a catheter to the surface. And based, I think, on this hierarchy, looking at this HLGT, my preference would be the previous term, the stoma site term, because it's not an application, it's not an administration site catheter. And of the two, it seems that it is regarded as a stoma. We saw the nephrostomy term in MEDRA. So based on that, my preference would be the stoma site term. So we would understand the meaning of nephrostomy as a learning point. We could do a top-down search in procedural related complications to find all the stoma complication terms, or we could search bottom-up for discharge. Consider the use of stoma versus catheter. That's what I told you. I didn't do the discharge search. I could do that one. Show you here. Are there any other discharge terms available? Site discharge, really. We've got 81 terms with discharge, so that might take us longer to look through. We could have a look here. Purulent discharge, to me that would, although we know it's white, I wouldn't make the assumption that it was purulent or infectious. We can see there by the hierarchy of purulent discharge, it has a link into the infections system organ class because that's the primary, so I wouldn't choose that one, although the white makes you think, is it an infection? So I would look through these to make sure I haven't missed anything, and it's better to choose a site term. So my preference would be stoma site discharge. So any thoughts, Caroline, from all those people who voted for the catheter site option?
Yes, there's one question. Would catheter site discoloration be appropriate as well?
No, I wouldn't choose discoloration, because discoloration to me suggests that the skin itself is discolored, the site where the catheter enters the body. This is a discharge, so this is a secretion or an exudate which is coming out of the hole or out of around the nephrostomy site. It's a discharge, so that's what's white. It's not the skin itself that's white or discolored. That's my thinking on that one.
No more questions.
Oh, great. Thank you very much. So that's my last one. I'll hand over back to you, Caroline.
Yes.
Thank you.
Here we are. Do you see it?
Yes.
Okay. So here's the exercise, the next verbatim, and a placement of a double J catheter is reported on the left side. So what do we need to ask ourselves? The double J, is double J, as reported here, an acceptable abbreviation? And is the site of the placement fully clear? And what does the additional information left tell us? Or we rather raise a query for further clarification? What will we do? So here's again your turn. Several choices here: catheter placement, catheterization arterial, catheterization venous, implantable, pleural catheter insertion. Also could be left or right. Ureteral stent insertion could also be left or right. Peripherally inserted central catheterization, again, could be on the left. Catheter could be inserted on the left or right side. Same holds true for jugular catheterization. Would you seek clarification? What would you do? Placement, JJ, double J catheter, left. You're still thinking? Only 37 answers received so far. So try to be as specific as possible. What is a double J catheter? We mentioned before that in the general introduction that sometimes you really have to reference medical textbooks or medical dictionaries in order to better understand what is reported. Because there are many very specific surgical interventions, not everybody is familiar with. Okay, we have 50 responses now. Let us check what you're going for. Ureteral stent insertion seems to be the favorite choice. Catheter placement as well. Several of you would also seek clarification, and jugular catheterization. It's considered an option as well. So, in searching for a catheter on the internet, you'll get hits for referring to double J stents. And it is expected that a double J stent is a ureteral stent with curving ends that prevent the stent slipping into the bladder or kidney. It is a device used for anastomosis between the renal pelvis and the bladder. And this is nicely shown in the illustration here, where you can also see the curled ends here, like little pigtails that help to keep the stent in position. And this type of stent allows urinary flow when a ureter is blocked to pathologies like an ureteric calculus or malignant neoplasm, for instance. And they can also support healing after stone surgery. So now we have a better understanding what was actually reported by referencing reliable internet sources as well. And let me again switch to my browser. Here we are. So if I enter catheter and search, we get many, many hits, 226, so a lot of to review. We have to narrow down our search. And if I search now with the advanced search feature of the browser, and I enter ureter and catheter and search, I find ureteral catheterization. So if I do again the right mouse click, go to browser, so it's grouped under the surgical medical procedures SOC, that's fully correct. And here we have the ureteral catheterization. And there's no more specific term, there's a retrograde ureteral catheterization. But we were told that this is actually a stent that is inserted into the ureter. So let us look at the neighbors here. we are under HLT ureteric therapeutic procedures, so something should be there. Maybe there's something more specific. And here we have the ureteral stent insertion. So this seems to be more appropriate than just ureteral catheterization. We know it's a stent. We don't know whether this, catheter is inserted through the urethra. So it's not a percutaneous surgical procedure. So that's why ureteral stent insertion would be the best match to our verbatim. So all other terms in the poll were not suitable because they are too vague, like catheter placement, or because they refer to vascular or pleural catheters. So it may be left or right, yes, for some of the vascular and pleural catheters, but the double J catheter is really a ureteric stent, as we saw in the reference that we looked at. So let me switch back. Here we are. What are the takeaways of what we just saw? First of all, we should always ensure that any abbreviation provided is not ambiguous. So this was not the case here, but if it would be ambiguous, we would, of course, have to raise a query. If a reported concept is not clear, we should refer to medical textbooks or dictionaries or reliable references on the internet to clarify the background of what has been reported. And we did this here. If you can't find a direct hit for the reported term in MedDRA, then perform a top-down search and always look at the neighbors of a potentially suitable term to ensure that you find the closest match for the given verbatim. And with this, we found that LLT and PT ureteral stent insertion is the best match for our reported condition here, for the, not condition, but investigation, surgical procedure. Any questions, Jane?
No questions, Caroline, on that one.
Okay, then let me continue. Next one, edema due to nephrotic syndrome is reported. So is the reported condition clear, or is a query needed? And do we have to split code, or can we find a suitable combination term which would cover all reported information here? Edema due to nephrotic syndrome. What would you do with this one here? Would you code to nephrotic syndrome worsened, edema due to renal disease, edematous kidney, nephrotic syndrome and edema due to renal disease, nephrotic syndrome and edematous kidney, or would you see clarification? What would you do? Edema due to nephrotic syndrome. The answers so far. I'm still considering your choices. Now let me again show the QR code just in case you have lost the connection here. It's the easiest way to rejoin. Okay, so let's see what we're going for. So most of you would just go to edema due to renal disease or nephrotic syndrome, and some of you have voted for nephrotic syndrome and edema due to renal disease. And some also have considered edematous kidney as the best choice. So let's have a look again into the browser. Oops. Here we are. And let me search for, go back to the basic search here and look for nephrotic syndrome. And search. Here we are. This is a diagnosis. If I do a right mouse click, say go to browser, we see it only has one SOC renal. Here we are under glomerulonephritis and nephrotic syndrome. It's the HLT under nephropathy. And nephrosis, nephrosis osmotic, nephrotic syndrome, and very specific ones. Also the nephrotic syndrome worsened. So what else? What about the edema? If I enter edema in search, I get, of course, many hits. 352. Again, we have to narrow down our search. And we know it's edema due to a renal disease, due to the nephrotic syndrome. So I would now restrict my search to the SOC renal and urinary disorders. Search again. And here we are, edema due to renal disease. And if we go again to the browser, we can see that it's grouped under primary SOC general disorders and administration site reactions under edema NEC HLT. It also, of course, has a secondary linkage to the renal disorders NEC HLT and SOC renal and urinary disorders. So let us look. Click this one here. And here we have edema due to renal disease. There's no one for edema due to nephrotic syndrome, but a more general term, edema due to renal disease. Edematous kidney was another choice. Go to browser, only one SOC linkage to renal. And here we have it. So just the same LLT, both in American and in British English. So these would be the choice. And the edematous kidney, it's a different medical concept, referring really to an edema of the renal parenchyma due to, for instance, renal inflammation. If it's because of an ureteric obstruction, then it would be classified as hydronephrosis. But here we are just told it's an edema due to a renal disease, in this instance, nephrotic syndrome. So the edema due to renal disease would be the best choice here. And if we look into the Dorlands again, so the main reference for MEDRA as well, it's a primary reference for MEDRA. Nephrotic syndrome is a general term for any of the large group of diseases involving defective renal glomeruli, characterized by massive proteinuria, lipiduria, and varying degrees of edema, hypoalbuminemia, and hyperlipidemia. So the question is whether the edema can be considered a characteristic symptom of the nephrotic syndrome. And we see here that it can be considered a characteristic symptom of nephrotic syndrome. It's mentioned here, together with other conditions. And how to handle these verbatims, where a clinical diagnosis is provided with a characteristic sign or a characteristic symptom. Now, if we look into the MEDRA term selection points to consider document, here's a screenshot of the most recent one from March 2022. Then in section 3, we can find the following table, and we have shown it several times already in our sessions here, explaining how to handle single diagnosis with its signs and symptoms. And we have two options to code such terms. One is the preferred one, is to code the diagnosis only. And the alternative option that you have is to code the diagnosis and the signs and symptoms, of course, if they are characteristic. So whatever you decide to do, you should apply your final decision consistently and also document the approach chosen in your coding conventions. So are free to choose either the preferred option or the alternate. Here again, our learning points. If you have to handle such a coding scenario, you will first have to clarify whether the reported signs and symptoms are truly characteristic for the given diagnosis. Because if you choose to code the diagnosis only with your coding approach, you will always have to code all signs and symptoms which are not characteristic for the reported diagnosis. So follow the PTC guidance and document the decision taken in your coding conventions, whether you choose to only code the diagnosis or whether you prefer to split code and capture all characteristic signs and symptoms in addition. Depending on your approach, you would either code the diagnosis only by assigning LLT and PT nephrotic syndrome, or you would split code and code the diagnosis plus the edema that was caused by the nephrotic syndrome by assigning LLT and PT edema due to renal disease. Any questions, Jane?
Yeah, we've got a comment from Martin that because nephrotic syndrome can occur with varying degrees, it means that the edema is not a symptom that's always present. So capturing the edema as well, as you've just said here in your alternate approach, may be sensible using medical judgment.
Yeah, but Dolan says different grades of edema due to renal disease. I think the grade, so the severity of the edema may differ. In the early stages, you may only have mild edema, but I think that nephrotic syndrome is really characterized by edema of different severity.
Yeah. It's an option you've given it, isn't it? So.
Yes.
Thank you.
Any further comments?
That's the only comment.
Okay. Then let's go to the next one. Next, a Descensus vesicae is reported. So do we understand what is being reported here? Is this reported in an accepted language? Is it unambiguous? Or do we need to query? Descensus vesicae. Again, your choice here. Would you consider this an anomaly of the gallbladder or bladder instability, bladder prolapse, cystoptosis, bladder malposition acquired, a bladder malformation, or would you see clarification here? What would you do with this one here? Descensus vesicae. You will have to check what Descensus is, what the meaning of Descensus is, whether there are synonyms for this term, and what is meant by vesica. So both are derived from Latin, so Latin medical term. And you will have to clarify what the meaning is. Now let us check what you're going for. Bladder prolapse is a favorite, but we really have a split of opinions here with regards to the other LLTs that were proposed. But bladder prolapse seems to be the preferred solution for this verbatim. So let us look into Dorlans again and check what descensus means. So the process of descending or falling where is explained. So, and there is a term for Descensus uteri, and we see a synonym here because it can be also named uterine prolapse. So Descensus seems to be a synonym for prolapse. Vesicae, translation is the bladder. So, and it could relate to the urinary bladder or the gallbladder. And another option in the poll was cystoptosis. And this is a very specific term because it refers to the prolapse of a part of the inner coat of the bladder into the urethra. So only a part of the inner coat of the bladder is prolapsing into the urethra. So very specific term. And now let us check in the browser again. And if I first have to clear my selection from what we had before in order to search all SOCs. And I look now for Descensus. This was the wording in our verbatim. And if I search for it, I get no results. If I search for vesicae, so the singular, I see that we have several vesical polyp, vesical rupture, vesical tenesmus. Let's see what urinary bladder polyp, vesical rupture, urinary bladder rupture, vesical tenesmus, bladder spasm, and vesical varices, urinary bladder again. So, and bladder spasm is also, go to browser, is grouped under renal and urinary disorder SOC. So vesicle is considered a urinary bladder condition in MEDRA. And it's also quite, I didn't find any reference referring to a prolapse of the gallbladder in any scientific article in the internet. So what is meant here is really a descensus, a prolapse of the bladder. And if I look for bladder and prolapse and search, then I find bladder prolapse, perfect match. If I go to the browser again, here we are, bladder prolapse. Here it is. And we see the cystoptosis is grouped under bladder prolapse. It's a specific, very specific type where, as you saw earlier, like the inner membrane, the inner coating of the bladder prolapses into the urethra. But here what we have reported is really a prolapse of the bladder. So that's why we would need to assign LLT bladder prolapse. Cystoptosis is really too specific in this instance. So that's why it's always important, if you see such terms, to refer to medical reference to clarify what is meant by that. And the other terms, like bladder malposition acquired, is, of course, it's a malposition, a bladder prolapse, but it's much too vague. And bladder malformation has a completely different meaning. And if you click on this, you see the hierarchy here in the term details window. You see that this is considered a congenital familial and genetic disorder. It's considered a congenital bladder anomaly. So the malformations, the malformation terms are interpreted as congenital conditions in MEDRA. Malformation would be incorrect, and bladder instability was another option. always important to check the hierarchy. If you see some terms that could be suitable for a given verbatim, go to browser again in order to check. Here we go to the primary SOC. It's multi-axial, this PT. Here we have the bladder instability, and you see it's grouped under PT hypertonic bladder, and with LLTs like overactive bladder, urgency frequency syndrome, low bladder compliance, and detrusor instability, for instance. So this would not be appropriate. This is not what has been reported here in this instance. So always, if you're considering an LLT, always check the hierarchy, look at the siblings under the same PT, look for other terms here in this grouping in order to verify that your consideration is appropriate, yes or no. And our learning points here is that medical conditions may be reported with medical terms which are derived from Latin and Greek. You may have received such reports as well in your coding environment. And in such cases, refer to medical dictionaries for clarification if you are not familiar with the terminology. And when confronted with such verbatims, make sure that the wording describing the condition and manifestation site is unambiguous. So here we had to decide whether this is really referring to the urinary bladder or the gallbladder. But as we discussed before, this is definitely referring to the urinary bladder. And use top-down and bottom-up searches to find the most specific term. So here's our final suggestion. We would code to bladder prolapse, same PT. Any questions, Jane?
No questions, Caroline. You've demonstrated the questions.
Okay, then I hand back over to you again.
Thank you very
much. To you.
Thank you. So let's see, do you see? Oh, where was I? I was there on it. There it is. Do you see this? Itchy rash due to high urea levels. Can you see that one? No.
Let me check. I have to switch screens in order to see it. Yes.
Good. So here our next one is, oh, let me see. No. Itchy rash due to high urea levels. What's being reported here? We've got two things. We've got a rash and we've got high urea level. Is there a relationship between them? Is this a recognized medical condition or a classic symptom of a high urea level? What do we need to do some referencing there? Should we split it or is there an appropriate LLT? Those are the questions that we would be asking. So what would you do? We've got urea high, uric acid high, uremia, hyperuricemia, uremic pruritus, itchy rash, or seek clarification. And you can select several here if you wish. Are you going to select one or several? I think it's looking for the relationship between the high urea and the itchy rash here. Is there a relationship or do we split code? That's the crux of the issue, isn't it here? I'll just give you a minute to vote. I hear that the poll is slow for some of you today. I'm sorry to hear that. We try to move on as quickly as we can to cover as many of the examples. Those that we don't cover, we'll carry forward to our next session in November, I think, isn't it? November, our next one. So I think that's everybody voted. What have you selected? Uremic pruritus is a popular choice, itchy rash and urea high. So this is the dilemma. Do you select a combination term, here uremic pruritus, or do we select urea high and itchy rash, not making any assumptions or diagnosis, and split code? That's the dilemma. That's the final. And you've echoed our thoughts when we saw this term for the first time as well. So we are literally, we are coding together, as it were. There we go, there's the browser. So let's have a look in the browser. Well, I'm sure we all know we can find urea high, we can find those, there's nothing clever there, we type it in And there it is, urea high as an LLT with a PT of blood urea increased. Itchy rash is also a term in MEDRA, a combination term capturing the fact the rash is itchy. And there's that one. So the high urea is an investigation term. The rash is with the other rashes in the skin and subcutaneous tissue disorders SOC. So we could split code, or let's have a look if there's a uremic rash. If there's an itchy rash, maybe there's a uremic rash. No, there's no uremic rash, but as if I just look up uremic, you'll see that we do have some uremic conditions, coma, gastromicropruritus. So there are some things given. This captures the itchiness. It doesn't capture the rash, but it does capture the itchiness. So that is a uremic pruritus there. I can do a right-hand click, go to browser. It's in the skin disorders, site of manifestation for the primary SOC allocation. There it is. Uremic pruritus is in with skin. So it's a judgment. Do we feel comfortable with that as a combination term, or do we split code? Excuse me. So our learning points is that we would understand any causal relationship between the reported events. We would not assume what the reporter means with that. That goes for any term that we code. And we need to be careful with similar sounding conditions. We added this because with urea and uric acid, it's always worth double checking yourself so that you're not using something with that sounds similar. So just double check there. We are using urea, which has uremia, not uricemia. So just double check that. And seek clarification of a causal relationship if you can't reference it or if you're not comfortable. So this is what we looked at it and we said, well, is it common to get a rash with urea? It might be common to get pruritus, but is it something else? Can we be sure? So we decided that we would split code and we would query to check, does the patient have uremic pruritus? Because of the fact it says there's a rash. I don't think that they mean uric acid. I don't think they mean that. If it was a sort of gouty toffee, I don't think it would fit that. So I think they do mean urea. It probably is uremic pruritus, but for comfort, we would query if we can to double check before making that assumption. Any questions, Caroline, on that one?
Yeah, somebody says, if we see that urea high is already reported as an AE, maybe itchy rash is sufficient to be coded.
Itchy rash, yes, I guess so. If the dates match, if it's not something that's coming and going, so you just be careful that you're not seeing something that was 6 months ago and they're reporting it again. But if it's all part of the same report at that time or pharmacovigilance report happening, then yes, itchy rash would be sufficient, wouldn't it?
Mm-hmm.
Okay, I'll do the next one. I won't stay too long, so we can maybe fit another one in. This one, we're staying with our renal terms. We've decided to do a focus on renal today, as you'll have guessed. Bladder inflammation after radiation therapy. Well, what's being reported here? Can we capture the post-procedural context in our choice of LLT? Do we need to split again? And is there a suitable combination LLT? Well, they're not telling us the patients had radiation therapy. That's not the purpose of the report. The purpose of the report seems to be the bladder inflammation. So how would you code this one? I'm not giving you a multiple choice now. I'm asking you, what do you think it would be? You may have received we do send the verbatim terms out a week in advance of the session. So if you sign up early enough, you will receive the verbatims. This gives you a chance to look at them ahead of time. Maybe if you've got a few moments, you can look in the browser and see what you would code it to. So we've got radiation inflammation, irradiation cystitis, cystitis radiation, so some of you are coding radiation inflammation and some of you are coding cystitis radiation, or split it. Well, if we can capture the context, that would be better. And I'll show you that in the browser, why if we can code the radiation context, it's ideal if we can rather than splitting. Bladder inflammation and radiation therapy. So let's have a look here. So let's have a look. So we've got bladder inflammation. This is how I would start, by using the words that the reporter has given us. Bladder inflammation. Does it exist? It does exist. It's an LLT and it goes under cystitis non-infective. Now this is interesting. Cystitis non-infective, because if we were to look for, that's in the blood, that's in the renal and urinary disorders SOC. If we were to look for just cystitis, we've got 121 here. So this isn't a good search to do. But even if I did an advanced search and I looked for cystitis, but not cholecystitis, coli, I could limit it to picking up cystitis from the urinary bladder then. Contains cystitis but doesn't contain cholecystitis. Oh, I haven't got anything now. What have I done wrong? Cystitis and not contains. What have I done wrong here? What have I done wrong? Let's go back to cystitis.
Show the LLTs. I think it's fine.
Search.
And show the LLTs.
Oh, I have to unclick them. That's why. Thank you. So here we go. I've done an advanced search that is looking for cystitis terms, but not coli. This will avoid all the cholecystitis terms. This makes it easier. I haven't got 121 and we can look down. And this is the one that some of you gave us, which was cystitis radiation. And I can see that that's under bladder infections and inflammations, but also radiation injuries. If I put my cursor on it, I can see the right-hand side here. The primary is the injury poisoning. So the primary is the radiation injury. Right-hand click, go to browser. Cystitis radiation, all the radiation injuries are grouped together. So that's why it's important, if you can capture the radiation link to the medical condition, as we can here. It doesn't mean it's infective. It is an inflammation. And it's more specific than your other suggestion, which was radiation inflammation. Some of you gave me this one, which is not wrong, but it's not as specific, because radiation inflammation could be anywhere. Here we're limiting it to the bladder by choosing cystitis radiation. Well done. So we would look for a combination LLT for any therapy complication, consider synonyms, and then be cautious when you do have any inflammation that you don't select an infection. We would always check the hierarchy, and that would be our suggestion. So we've managed to do 10 today. I see that we're just coming up to 10:30 here in the UK. That leaves us the 2 examples that we'll carry forward to next time. We'll start with these last 2, finishing off the renal.
Intermittent potassium level too high to start dialysis.
That's next time. So I just want to point out to you that we do, if you're new to these sessions, we do record them all. We don't give you the slides, but we do record them, and they're all available. This is session 17. All the previous sessions are available on our YouTube channel. So if you're interested in looking at any previous ones, you can do. And also what I wanted to point out is you see today we've been doing renal examples, and it may be that you have a particular interest in a therapeutic area. So just before we go, I will show you how you can do this on the training section of our website. If you look under training materials, you'll see there's a document under coding section. There's the Let's Code Together section. These are where you can look at the YouTube playlist, and the session has been done in other languages, so that might be of interest to you as well by our colleagues around the world. And there are 2 documents here. There's a term index, and there's a document explaining how you use the index. So as you'll appreciate, having done 17 sessions, we've got quite a list of terms. So if you go here, you can look at all the previous verbatims that we've covered. And if there are any that are of interest to you, you can click and go directly to the recording on the YouTube channel for that session. So just that's something we don't always show, but I'll just take a moment to show you that. So you can also look by category. So today we did renal. So we realized we didn't have many in renal, but we could go here. There'll be a section now. It'll be listed as renal. If you're interested in, for example, ophthalmology, you can click there and it will take you directly to the previous terms that we've covered that are under the eye disorders. Therapeutic.
We have we name it urology. It's on the.
Oh, it's under
at the end of.
There it is, Carol. Yeah. There it is. You're right. The way we.
Mm-hmm.
It's a good job you're here today, Caroline. You're keeping me on the straight and narrow. Thank you. We decided not to call them the same as the SOC names because sometimes the term might not code into that SOC, as we saw there with the bladder inflammation with radiation. So that's why we decided we would call them more their clinical name rather than their SOC name. Thank you, Caroline. So let me go back because I'm rushing to get to wrap up and not take up your time. So what we do have is we have our instant survey here. This is your opportunity to tell us what you thought of the session, what you'd like to see. If you have any requests for particular terms or particular topics, this is where you can let us know. You will also receive a standard SOGO survey that comes with the email that you receive following the session. And you can download your certificate. If you were here for the whole session, you can download that from our website under the self-service application. While you're doing that, I'll just go back to the website. I did that very quickly. Here it is, training materials. You go to the website under the heading of training, and then there's Let's Code Together. There's the term index and a list there of a document, how to use the index. So you can see we probably must be over 150 terms now, 17 sessions. We probably have around 150 to 160, I would think, verbatims. I would say probably around, 150 or so available to you. Any questions or anything else, Caroline, before we let everyone get on with their day?
No.
No? Any other comments from you?
No comments from me, all clarified from my point of view.
Thank you. So I hope you found that useful. I hope you find the index and the YouTube recordings useful. Please do give us as much feedback as you can and ideas in the surveys. And otherwise, we thank you for your attention today, and we shall look forward to seeing you next time or at one of our other events. I have remembered something I wanted to say. Next week, we have our first face-to-face training happening again. It's happening in Copenhagen in Denmark. So if this is something that is of interest to you, we've had some cancellations and there are still places available. So email us if you are interested, because the registration's closed, but based on the cancellations, we do have places. So if you're in Denmark, I see somebody was in Denmark. If you're in Denmark and you want to join us and you're not already signed up, we'd love to see you. So that's just something I wanted to say before you leave. Okay, so good luck everyone with your coding. Stay safe, enjoy the rest of your day, and we look forward to seeing you in November. Thank you very much, Caroline, as well, for your collaboration. Always fun.
Thank you, Jane.
Bye-bye. Bye-bye.
Bye-bye, everyone. Bye-bye.